Good afternoon, everyone. Today my topic is the TENIS. TENIS stands for Evaluation Trans Thyroglobulin Elevation but Negative Iodine Scintigraphy. Uh, Differentiated thyroid cancer is most common thyroid cancer and is mostly are indolent tumors. Surgery and radioactive iodine therapy are standard modality of treatment. During radioiodine therapy, cytocidal amount of radioactive iodine is trapped by the thyroid follicular cells with the help of sodium iodine symporter and is further organified in the levothyroxine and triiodothyronine. The 2-3 slide I will discuss about the sodium iodine symporter. Sodium iodine symporter is the integral plasma membrane glycoprotein. It is located in the basolateral membrane of thyroid epithelial cells. It couples inward transport of two sodium ions and one iodide ions against its electrochemical gradient. This is thyroid follicular cells. The sodium iodine symporter is located along the basolateral membrane, and with the help of symporter, sodium and iodide ion are incorporated within the cells. Again, the picture of sodium iodine thyroid follicular cells. This is the basolateral membrane. This is the apical membrane. The sodium iodine symporter is located along the basolateral membrane, and two sodium ion and one iodide ion is incorporated within the cells. And sodium ion again with the help of sodium potassium ATPase pump, it is go outside of the cells. Electrochemical sodium gradient that allowed the sodium iodine symporter to be functional with the help of sodium potassium ATPase pump. Sodium iodine symporter mediated iodide transport is inhibited by the competitive inhibitor like thyrocyanate and perchlorate. It is not a thyroid specific protein. In lactating mammary glands, gastric mucosa, salivary gland, lacrimal gland, choroidal plexus, skin, placenta, and thymus also showing also have a sodium iodine symporter on their cells. Main importance of the sodium iodine symporter is this is the few things which increase the expression of sodium iodine symporter. Like TSH, when TSH level is the high, sodium iodine symporter expression is more stimulated, and iodine is more taken by the follicular cells. Other thing is the retinoic acid, which used in the radiodifferentiation therapy. It also re-stimulates the iodine uptake. And stone deacetylase inhibitor, it also increases the sodium iodine symporter expression. Next, PAX8 expression also increase the sodium iodine symporter expression. Negative impact is the iodide. Iodide decrease the level of the sodium iodine symporter expression. And estrogen and thyroglobulin. When thyroglobulin level is rise, sodium iodine symporter expression is reduced on the cells. The recent data also shows when in the thyroid follicular cells, the poorly differentiated thyroid follicular cells, the sodium iodine symporter is located intracellularly, not on the cells. So when the cells become poorly differentiated, that number of the sodium iodine symporter on the surface is reduced. It is incorporated inside the cells. On the follow-up, monitoring of the serum thyroglobulin level is important. For the unstimulated TG level is more than 2 nanogram per ml. For the stimulated TG, there is a threshold value is 10 nanogram per ml. So what is TENIS syndrome? In the minority of the patient with a diagnostic whole body scan initially or in the follow-up after the radioiodine ablation, there is no abnormal increased radiotracer uptake anywhere in the body, but with elevated serum thyroglobulin. Commonly, it occurs in the age of 45 to 50 year age. The main cause of TENIS syndrome is is the microscopic remnant of normal tissue, which is not seen on the iodine scan. Second one is the metastatic disease not visible with the diagnostic dose of iodine 131. Sometimes a patient present with the lung mets, the small lung nodule not seen in the diagnostic scan, but when we do the therapeutic scan, it shows on the iodine scan. So this is the cause when the iodine scan is negative in case of lung cancer and thyroglobulin level is increased. This is cause of TENIS syndrome. The other one is the inadequate serum TSH stimulation. When serum TSH is not adequately rise, then also we can see the picture of TENIS syndrome. And other one is the macroscopic metastatic disease, but with mutated and loss of sodium iodine symporter. When the cell is metastatic, when disease is metastatic, but the sodium iodine symporter level is reduced on the cells, that also present with the TENIS syndrome. And false elevation of the serum thyroglobulin should be excluded. They're the rare because false decrease of serum thyroglobulin is more common than the false elevation. But this is the also factor we have to reduce the false elevation of the serum thyroglobulin, and combination of all these factors. So how to diagnose the TENIS syndrome? By proper history, do the physical examination, and when after the proper examination and history, we go for the structural imaging. First we do the sonography, CT neck and chest, and after that we can go for the 18F FDG PET CT. And management, we will go for the empirical iodine 131 therapy. If a tumor is only 1 to 2 site is present, we can advise for the surgery also. Extend beam radiotherapy. Other one is the redifferentiation therapy we use for the TENIS syndrome. After this redifferentiation therapy, iodine 131 uptake is increased. And for the response evaluation, we do structural imaging like CT scan or sonography, or iodine 131 whole body scan and biological marker. So first we go for the history. Negative iodine scan may be caused by the dilution and competitive inhibitor of the radioiodine tracer. Sometimes we should ask for the patient for any dietary source, patient taken any iodine containing medicine or any sea fish जो have any iodine content, and any reset injection of the iodine containing contrast media, because sometimes it can cause negative iodine whole body scan. So proper history should be taken. After we go for the medical examination, we see the metastatic site, most commonly in the lymph nodes of the neck. Other common site is the lungs and bone. So through neck examination, ask the history, any hoarseness of voice, any bony tenderness is present or not. So first we do the sonography. It is easily available and cost effective. So it first be acquired by the of neck, followed by the FNAC. And the malignancy feature is the internal punctate calcification, longer AP diameter than the transverse diameter, and infiltration of adjacent structure. All this information given by the sonography. When stimulate TG is right, the sensitivity of the sonography is up to 96%. Then we go for the CT chest, the lung and most common site of metastasis. So USG cannot detect the mediastinal disease. In this case, CT chest can be acquired. Then we go for the FDG PET CT. FDG PET CT has a good sensitivity in detecting the iodine negative differential thyroid cancer. The sensitivity of the FDG PET CT in detecting the metastasis, when TG level is rising, then sensitivity is increased. When TG level is more than 100, the sensitivity of the FDG PET CT is increased more than 90%. This is the case of 60-year-old male patient presented with the follicular carcinoma of thyroid. TG was within normal limit till 6 years after the surgery. Then it is found increasing level after the 6 years. And when we go for the iodine 131 whole body scan, it was normal. The PET CT was suggested we show evidence of C7 and D12 vertebral metastasis. These are C7 vertebral mets and D12 vertebral mets. And patient undergone for the palliative radiotherapy on both the sides, and patient remained asymptomatic and was kept on follow-up. This is the follow-up PET CT scan, which showing a decreased uptake. This is a metabolic resolution of the C7 and D12 vertebral lesions. The potential indication of the PET scanning in the thyroid cancer, the strongest indication for the PET imaging, the thyroglobulin positive with unknown tumor localization to detect the additional metastasis. And other most important advantage of the PET scan is to determine the long-term prognosis and post-treatment response assessment. How we manage the TENIS syndrome? Already we mentioned the surgical resection, the empirical high-dose iodine therapy, external beam radiotherapy, redifferentiation therapy, tyrosine kinase inhibitor, gene therapy, and somatostatin analog we use for the treatment. The surgical resection is suspicious nodal finding in the neck, surgical exploration resection before the consideration of any systemic treatment. This is the best choice. When you have seen any neck node is present and it is surgically approachable, to go for the surgery, this is the best treatment for the TENIS syndrome. The lung metastases are generally multiple and unresectable, and sometimes may be resectable when detected early. Isolated bone and brain metastases can be removed with the surgery. The next is the empirical high-dose iodine therapy. When TENIS syndrome confirmed and no identification extracellular tumor is resectable tumor, therapy must be considered for the empirical iodine 131 therapy. The one study was done by the Mac et al. They included 310 patients. The 57% of the patients with a functioning thyroid tissue on post-treatment whole body scan. When in the post-therapy whole body scan was done, we found the functioning thyroid tissue. And among 271 patients, after the empirical dose of therapy, the decrease in the serum thyroglobulin level. How they decrease the serum thyroglobulin level? By causing the reduction of the thyroglobulin producing cells. The Mac et al. Both suggested that empirical iodine therapy justifies when thyroglobulin level is more than 10 nanogram per ml. Then we advise for the empirical iodine 131 therapy. For the isolated metastasis in the neck, brain, and bone should be resected before the iodine 131 therapy. Finally, simply visualizing the differential thyroid cancer after the high dose iodine therapy doesn't mean that sufficient radioiodine has been concentrated by the tumoricidal effect, because the tumor cells have acquire that sufficient amount of radioiodine to kill that cells. The other one is the external beam radiotherapy. It is limited role in the metastatic thyroid cancer because tumor is not very radiosensitive and radiotoxic to the trachea and spinal cord. This is the dose mostly given is 65 to 70 gray. The side effect is the esophagitis and tracheitis after the radiation, and long-term side effect is the neck fibrosis, dental caries, and tracheal stenosis. The IMRT treatment have some benefit than the external beam radiotherapy. The other one is the redifferentiated agent that reactivate the sodium iodine symporter. The monitoring the therapeutic response, TG value represented therapeutic response or failure. The drug for redifferentiation is the retinoic acid, the most commonly used, thiazolidinones, histone deacetylase inhibitor, thalidomide, the inhibitor of the methylation, and HMG-CoA reductase inhibitor like atorvastatin and lovastatin. Its drugs are used for the redifferentiation treatment. This is the paper published by the Adam Zwerke et al. The application of the retinoic acid in patients of 131 iodine scintigraphy negative patients of metastasis of differential thyroid cancer. They included 11 patients with the disseminated papillary thyroid cancer and higher serum TG level. And after the retinoic acid treatment, the increase of the iodine uptake was observed in 5 patients and decreased thyroglobulin concentration was observed in the 9 patients. In that group, iodine uptake was observed in the 4 patients with distant metastasis. The other treatment is the thiazolidinones. These are most commonly used drug is the rosiglitazone. The anti-diabetic compound is a paroxysmal proliferator activated receptor gamma, which inhibits the cell proliferation and induce the apoptosis. Rosiglitazone has been reported to inhibit the proliferation and induce the apoptosis and also increase the sodium iodine symporter mRNA. The one paper is published by the Tampunogol et al. The rosiglitazone effect on the radioiodine uptake in thyroid cancer patients with high thyroglobulin but negative total whole body scan. The 23 patients they are included, in which PPR gamma positive staining was done in thyroid biopsy. 7 had strong positive, 9 had weakly positive, and 7 had negative staining. The strong positive cases in the 5 patients have positive post-treatment whole body scan, both diagnostic and post-treatment whole body scan after the rosiglitazone therapy. Rosiglitazone therapy can increase the radioiodine uptake most of the patients. The other one is the valproic acid. Valproic acid is the histone deacetylase inhibitor. It promotes the differentiation in the poorly differentiated thyroid cancer, apoptosis induction, and inhibits the cancer cell growth. The valproic acid is induce the sodium iodine symporter expression to increase the iodine uptake. Other pathway is to activate the caspases to increase the apoptosis. It also increases the P21 level and cell cycle arrest in the G1 cycle. The other is the tyrosine kinase inhibitor like sorafenib, geftinib, sunitinib we use for the redifferentiation therapy. The other one is the somatostatin analog. Somatostatin receptor detected in the vivo is significant number of the patients with the TENIS syndrome can be used for the treatment. The summary is the TENIS syndrome, we have to take proper history, physical examination, structural imaging in the sonography, CT, neck, chest, and FDG PET CT. And the management part, we use the iodine 131 therapy, surgery, external beam radiotherapy, mainly redifferentiation therapy for the TENIS syndrome. After the redifferentiation therapy, patient should try for the radioiodine therapy again, and most of the patients had responded after the treatment. And for the response evaluation, for the structural imaging, iodine 131 whole body scan and biological marker like serum thyroglobulin and antibody is used for the response evaluation. Thank you so much.
Dr. Agarwal, nice talk. For empirical iodine therapy in thyroglobulin positive patient, how much dose we give?
Generally, we give 100 to 200 millicurie. Minimum, we give 100 millicurie iodine therapy.
And what about the patient which fall into the intermediate group, like thyroglobulin level is 5? Okay, so it is not more than 10. So for this patient, what is the suggestion? Because patient come to us and poking us, so what is the reason we cannot find?
Where the thyroglobulin, because empirical iodine therapy is more effective when thyroglobulin level is high. So when the thyroglobulin level less than the 10, so we should go for the proper diagnosis. What is the rise of the thyroglobulin level? Sometimes we found on the ultrasound neck any.
If everything is negative, it is a TENIS syndrome.
So we can follow up that patients.
Okay,
Yes.
thank you.
Thank you so much.